Hi, I'm Dr. Derek Plausinis. I have a subspecialty interest in shoulder and elbow surgery. I'd like to talk to you today about shoulder replacement surgery. In general, there's three reasons for a patient to consider a shoulder replacement: pain, pain, and pain. There are some other considerations and other reasons that are less common, but in terms of patients deciding on whether or not a shoulder replacement is best for them, pain is usually the best driving force. Typically, with shoulder replacement surgery, in the long term, patients experience excellent pain relief about 90% of the time. Most patients also experience improvement in function, but the amount of motion gain is variable and depends on the ultimate diagnosis, how patients exercise afterwards, and other patient factors. There are generally two main categories of shoulder replacement surgery. The first kind is called an anatomic replacement. So anatomic meaning you're trying to restore the normal anatomy. So in this model here, you have a shoulder blade. You would have the arthritic socket piece. So there's a plastic socket piece put on it. So you're trying to keep the normal anatomy. And on the humerus side, there's a metal ball placed, typically with a metal stem that goes inside the bone. And so the anatomic replacement is trying to replicate the normal anatomy the same way a hip or knee replacement is done. So the metal ball goes where the ball goes and the plastic socket. The reasons we would consider an anatomic replacement is typically osteoarthritis or regular age-related wear and tear arthritis. And for that, patients need an intact rotator cuff tendon. A bit of wear and tear of the tendons are fine and a normal part of aging, but the overall structure of the rotator cuff tendon has to be intact and strength has to be preserved. If you don't have preserved rotator cuff strength, the shoulder rides up, the socket can loosen, and the outcome is disappointing. The other type of shoulder replacement that's commonly done now is called a reverse designed total shoulder replacement. It is a total shoulder replacement, but it's called a reverse designed because the ball and socket are reversed. So in this model, a ball has gone on the socket piece, and then a socket has been made out of the normal ball part. So it's reversed anatomy, and then goes like that. This also has a stem on it. With a reverse shoulder, the most common indication initially was a shoulder that did not have functioning rotator cuff tendons. So you no longer needed rotator cuff tendons to hold the socket in. Your deltoid alone could elevate the shoulder. The reasons have expanded to use a reverse shoulder. Now sometimes patients with severe socket wear or glenoid wear, where the shoulder is sitting backwards quite a bit and needs a bone graft, are also probably better served with a reverse design shoulder replacement. Those are complex scenarios and discussed with the patients on an individual basis, but that's another increasing indication. Other indications where the rotator cuff might be unreliable isn't someone who's had previous deformity or had a previous significant fracture and subsequent weakness, and the rotator cuff is unreliable. Before surgery, in the office, I usually advise patients to maintain shoulder muscle strength. This can be difficult to do with a very painful arthritic shoulder, but you can do a strengthening program called isometric strengthening, where you simply exercise by pulling on things or pushing on things. So you're stimulating your rotator cuff muscles and not actually moving your shoulder. If you look up on the internet, isometric rotator cuff strengthening, you can find numerous guidelines for how you can do a simple exercise program to maintain your muscle mass. The other important preparation before surgery is to plan your life being one-handed for up to 6 weeks. This means taking time to think about how you're going to put on your shoes and get dressed and wash. And most of those things can be done by simply leaning forward and allowing the arm to dangle. So your other hand moving your surgical arm or allowing to dangle are both fine. Having people there to help you for the first few days in particular is often quite helpful and nice for your sense of security and to make life a little easier for you. The hospital calls patients to tell people when to come into hospital. Typically, most shoulder replacements these days are done as a day surgery procedure. Day surgery works out quite well for most patients when they have good home supports and are well prepared for surgery. Patients who have mobility difficulties or particularly complex surgeries can sometimes stay overnight, but virtually everybody goes home the morning, the day after surgery, for the small number that stay in hospital. Any shoulder replacement is a significant operation and as major as any major joint replacement like a hip or knee replacement. It does come with the standard surgical risks for any joint replacement. Infection is up to 1 or 2%, and we do many things such as cleaning the skin beforehand, pre-op antibiotics and post-op antibiotics to try and prevent infection. Neurologic injury can occur. This is uncommon. Up to 4% of patients will have some temporary nerve symptoms, but long-lasting permanent nerve problems are quite rare and typically less than 0.5%. A blood clot after shoulder replacement is quite uncommon. Typically that doesn't occur in the arm, and if it does, it's usually not very significant. They can dislocate. This is uncommon and occurs less than 4% of the time. Blood loss needing transfusion is very uncommon after shoulder replacement. The very rare number of patients who have that typically come in with very low levels of hemoglobin to start or have complex revisions. It's uncommon. After shoulder replacement surgery, most patients are in a sling for 4 to 6 weeks. I typically don't mind at all if patients don't wear their sling at home, but the most important element is for patients to keep their shoulder loose and relaxed. It should look loose and natural. When patients are seated, they can loosen a sling off their neck and let it rest on their lap, or if they want to walk around their own house without a sling on, that's completely fine, so long as they're keeping their shoulder muscles nice and loose and relaxed. After 4 weeks, most patients can start to use the arm for light waist level activities. Anything with the elbow below the shoulder is considered waist level and fine to start for most patients at 4 weeks. At 6 weeks, patients can then start to do reaching activities and stretch more aggressively, and this is when physiotherapy starts. It's really important from 6 weeks onward that patients are really diligent with a frequent home stretching program. Patients are seen for follow-ups after 2 weeks and 6 weeks after surgery, and then a longer-term follow-up at 4 months to 6 months, or as needed anytime in between. Generally these days, the outcome for most patients with an anatomic or regular replacement and a reverse replacement are very similar. As mentioned earlier, about 90% of patients have excellent pain relief with a shoulder replacement. Persistent pain after surgery, however, is a complication and does occur, although uncommonly. Most patients experience improvements in motion, but losing motion or not experiencing an improvement in motion is also a possibility, although uncommon. As noted earlier, the amount of motion gains is variable. With a reverse shoulder, some patients can lose some degree of rotational motion, such as reaching behind the back. That's normal for this implant. It's impressive what motion gains some patients can make, but it's not a normal joint, and rotational motion can sometimes be lost.